Alrighty, well, my time is showing 12:30, so let's go ahead and jump in. Welcome to everyone that's joining us today. Go ahead and introduce yourselves in the chat so we can get acquainted better while you're joining. Just select everyone when you're using the chat function. And just so you're aware, following today's presentation, there will be time for questions. So we're going to use the chat function to do that towards the end. Thank you again for joining us. My name is Rebecca Farrow. I'm part of the BHIPP team. I'll be introducing the presenter for today, Dr. Pine, and facilitating the Q&A at the end of the session. For those of you that are unfamiliar with BHIPP, I'd like to provide some information briefly about our program. Maryland Behavioral Health Integration in Pediatric Primary Care, aka BHIPP, is a child psychiatry access program that supports the ability of pediatric primary care providers to address and manage mental health concerns. BHIPP is a free statewide program that offers telephone consultation, resource and referral networking, care coordination, and training and educational opportunities. The BHIPP warm line is staffed by child mental health specialists and is available Monday through Friday, 9 to 5. And our phone number and website is in the chat for you if you'd like to learn more about our services. So it is my pleasure to introduce today's session and our presenter for supporting LGBTQ youth in the primary care setting. Dr. Elise Pine is a board-certified pediatric endocrinologist and trans youth lead physician of the Gender Joy program at Chase Brexton Healthcare in Maryland. She earned her bachelor's in English and Natural Sciences at Case Western Reserve University in Cleveland and her MD at Washington University in St. Louis. She completed her pediatrics residency training in the Mount Sinai Hospital in New York and moved to the Baltimore area for fellowship training in pediatric endocrinology at Johns Hopkins. Dr. Pine began working with gender diverse children and adolescents while serving as an assistant professor at University of Maryland Medical Center. Transgender care has been the most interesting, exciting, and rewarding part of her clinical practice. The Gender Joy program serves over 1,800 transgender and gender diverse youth from ages 4 to 26, and Dr. Pine has published research and clinical articles related to transgender care, and she lectures frequently. So thank you for joining us today, Dr. Pine. We are so grateful to have you here with us to discuss this important topic and have your expertise over the next hour.
Thank you. I'm very happy to be here. I'm going to launch right into my slides because I want to make sure that I can hopefully get through all the material and still have time to answer people's questions. So I'm going to go. Okay. Would like to discuss supporting LGBTQ youth in the primary care setting. Just in terms of disclosures, I have no financial conflicts of interest, but the medications that I'll be discussing today are off-label use. They're not FDA approved for the indications I'll be discussing. I'd like to talk just about best practices for creating welcoming and affirming office environments when dealing with LGBTQ youth. Talk about some of the medical options for transgender and gender diverse youth, and some resources around the community and some national resources, and also talking about some of the challenges that these youth face, but also some things that can help to be protective and help people with resilience. The program that the lead physician for is Gender Journeys of Youth, and we offer a lot of different services: primary care, behavioral health, child and adolescent psychiatry, case management. I'm the pediatric endocrinologist, and we also have a center for LGBTQ health equity, and we do a lot of resources and trainings for individuals and for communities, services, and organizations. This is just kind of showing a little bit about the program. We have some people on blockers, more people who, especially who are older, on hormone therapy, breaking down of gender identity, more people who are transmasculine than transfeminine, also a significant proportion of people who are non-binary. And again, in terms of age, smaller proportion of people who are the younger children, more into later adolescence, and more who are young adults. When making a welcoming office, it's very important to use inclusive language on paperwork, on your website, when asking questions, also in terms of paperwork that's around the office, brochures, posters, having posters that demonstrate all different kinds of families, all different kinds of relationships. Pride flags and other things can show that you're an ally and that you're welcoming. It's also very important that language use is really uniform throughout the office. Sometimes the doctor might be using, exactly all the right terminology, but if somebody in the front office staff is using something that's offensive or not using someone's pronouns, it can really make the office feel unwelcoming for people. If somebody does disclose gender identity or sexual orientation, there's things that you can say to help somebody feel comfortable, thank them for their trust, use respect. If they are saying it in confidence, keep that confidence. Ask what you can do to help support them. Ask if they have support in other places and help them to find that. Ask if they want help in discussing it with other people and how they're feeling. Unfortunately, people don't always kind of have the right things to say. Sometimes people can say other things. You're just confused. It's a phase. Don't tell people. Are you sure? Maybe that's not really the truth. Or based past relationships to say someone to invalidate somebody's feelings or somebody's identity. They looked at experiences. There's an article from 2017. The doctor said I didn't look gay. So sometimes doctors kind of saying, well, that can't be true. You know, that's not what your experience is. And they asked people about their experiences in the doctor's office. So people had experiences of non-disclosure that they didn't share with their pediatrician or family doctor because either the person didn't ask, because they felt internalized stigma, they felt ashamed, or they just said, this isn't related to my health, it doesn't matter. Or they didn't disclose, and what they found was disbelief or discrimination. They had negative experiences, but they also had the possibility of a good effect of affirmation and respect. So people did have the chance of a good experience as well. You know, we are, as pediatricians, we are asking people about their relationship, sexuality, sexual practice, and all kinds of things. And language is really important. So this was an article from 2014 looking about inclusive language when asking during a well child visit, teenage visits, asking about sexual orientation and sexual practice. And they were divided into direct inclusive, direct non-inclusive, and indirect non-inclusive. So for instance, direct inclusive language might say, any romantic stuff, any crushes, have you had sex with this, boys, girls, both, you know, what's the gender identity of your partner? What was the sex assigned at birth? Just really asking openly what type of relationship this is. You know, are you dating anyone? Is this a boyfriend or a girlfriend? Really just being open about any type of relationship it could be. Well, who is your partner? What kind of partner do you have? Direct non-inclusive is, you know, if you see someone who's a girl and saying, do you have a boyfriend? Are you having sex? Are you using birth control? You're assuming the partner, you're assuming the kind of sex they're having, you're assuming the need for contraception. And if you look, the direct inclusive was 3.3% of the communication. So almost all of the communication was non-inclusive language, whether it was direct or indirect, even if they're just saying, oh, boys and girls have sex together. So they're kind of, again, assuming a lot about what kind of relationships are happening. So it's really important that you want to have good relationships and grow trust. You want to ask people respectfully, what do they like to be called? How do they like to be called? What language are they using? And use that same language so that they can feel comfortable. Sometimes people, adolescents, use terms that you won't understand. I don't always understand the terms that they're using. They have new terminology that I don't always know, and just ask for clarification. Sometimes also there's terminology, but it may mean something different to different people. Sometimes somebody might say that their identity is, they might say, I'm a demigirl. And that might mean, or I'm non-binary. And non-binary for some people might mean, for instance, I feel both male and female. And for other people, I mean, I feel neither male nor female. And so it can mean very different things to different people. So just asking and saying, you know, oh, okay, can you explain what you mean by that? You know, I'd really love to learn more about how you're feeling. Being non-judgmental, direct, specific, and also explaining, you know, confidentiality, and also what you can't keep confidential. These are some forms. We're always collecting what we call SOGI data, sexual orientation and gender identity. When somebody comes in and they're filling in paperwork, you do need, you know, specific information. So people can ask, what is your sex on legal documents? Because that's what's going to be on somebody's insurance paperwork, and that's might need to match for their prescriptions or lab orders, for instance. And their name on legal documents has to be matching that. But you also can ask, what name would you like us to use, and what are your pronouns? And that's how people should be addressed and discussed, whether you're in the room with them, when you're out of the room with them, when you're talking about them in the third person, always using the pronouns people ask. Down towards the bottom, there's also questions asking about sexual orientation. Do you think of yourself as lesbian, gay, or homosexual, straight or heterosexual, bisexual, something else, don't know or choose not to disclose? And then there's underneath, what is your current gender identity? And there are options: male, female, transgender, male, transgender, female, gender queer, non-binary, additional category, fill in the blank, and choose not to disclose. So again, there's other options for people to write in. Some people say I'm agender, etc. There's other things. And then also, what sex were you assigned at birth? And that's helpful as well, because you may need to know for proper medical care, somebody's anatomy and somebody's anatomy inventory, what parts do they have and what kind of screening do you need to do? So it's helpful to know both somebody's assigned sex at birth and also their gender identity to give the proper care. In terms of numbers, increasing numbers of adolescents and adults are identifying in the LGBTQ community. Sexual minority youth in 2017 was 11.2%, and in 2019 was 15.6%. So in a prior study, 0.7% of youth had identified as transgender, and then in 2017, 1.8% transgender and 1.6% unsure. So again, a lot more people identifying as not cisgender. A Gallup poll for adults found LGBT adults to be 3.5% of the population, and then in 2020, 5.6% of the population. So again, increasing. But also note that a lot more of youth, a lot more young people are identifying in the LGBT community as compared to adults. In the HRC, the Human Rights Campaign poll, they found about 2/3 of transgender and sexual minority youth didn't talk about that with their pediatricians, with their healthcare providers. They didn't talk about their sexual orientation or their gender identity. So many people are not comfortable in the healthcare environment. And sometimes with good reason. Some people have bad experiences. And discrimination in any kind of environment can have direct health consequences. There are some states that have better policies than others in terms of protection, and states that have protective policies, people do better in terms of their health outcomes. People without protective policies do worse in terms of mental outcomes. People who've experienced discrimination have much more serious health problems than people who don't. And people who have high levels of anti-gay prejudice have a shorter lifespan. So these problems of prejudice can have very serious health outcomes. In terms of transgender health, this is from the US Transgender Health Survey, and many people were experiencing psychological difficulties. 41% had some psychological difficulties prior to, in the time of completing the survey. And many people also had serious problems in trying to get health care. People had problems seeing their doctor, they felt harassed, they had been refused treatment, they were assaulted, they had to teach their provider about their own health needs. And so people ended up not going to the doctor, either because they were feared that they wouldn't be treated correctly or they couldn't afford it. And unfortunately, schools also are many times not welcoming for LGBTQ youth. Many students are being verbally harassed. There are people who are being even physically assaulted. People are missing school because of that, because of the bullying that's taken place. There's these are national statistics. There's statistics for each state as well. And even though Maryland overall has very good policies, there's still bullying that occurs in Maryland as well. So in terms of meeting patients and seeing what they need, harm reduction is a good policy, seeing where people are, trying to help people to get to a healthier space, but meeting them where they are, honoring their autonomy, knowing when they're ready to change, and seeing what can motivate people to change. Homelessness can also be a serious issue for LGBTQ youth. Family rejection is the main cause. That sometimes when people discuss their sexual orientation or gender identity, they may not have stable housing anymore. And 40% of the homeless youth population is LGBTQ versus 5% of the general youth population in this survey was LGBTQ. Social networks can be very, very important. Of course, developing your social network is, of course, a very important part of adolescence in general. But it also helps with identity formation. And it's very important sometimes for young adults who are understanding their sexual identity and their gender identity. It can be very helpful to join groups like PFLAG, And many schools also have a gay-straight alliance, or sexuality and gender alliance, SAGA, many of the schools are calling it now. A lot of times also some of these programs work with other things. PFLAG might have guest speakers, for instance, or other mentors who can help show possibility models. The idea that, you know, though things are hard now, there are many transgender LGBT adults who have been through college, have a job, have a family, and that there is hope for the future. There are many coping strategies that can help with resilience. Coming to self-acceptance and fighting against internalized homophobia, internalized transphobia, and self-acceptance. Connecting with support of others are really important, just having that network of people who are supportive, particularly if family is not. Self-care behavior, being involved in social activism can very much help because it can help with a sense of pride. Cognitive and behavioral flexibility, being able to kind of understand where things are now and having, again, sort of hope for the future and acceptance and self-care. This is a slide that starts to talk a little bit about gender identity and disclosure, because I do get a lot of questions when I talk about doing gender care for youth. A lot of people ask questions about, you know, can young people know this? How do young people know this? What are you doing to young people? And this is talking again from the US Transgender Survey, and they asked people, when did you first know that something was different? You know, how old were you? And then they asked also, you know, when did you know you were transgender? When did you get that idea? And when did you start telling other people? And you can see on the left, a lot of people feel different at 5 and under, 32%, and even 28% at 6 to 10. So children really did start to know that they felt different. Not everyone recognized what that was. And in the middle slide, it's showing that 28% kind of recognizing that at 11 to 15 and 29% at 16 to 20. So people starting to discover what exactly that difference was and what it meant, happening around puberty for a lot of people. And then being able to talk about it and disclose and tell other people, happening a lot in late adolescence, 37% at 16 to 20. So while a lot of people sometimes kind of say, well, you know, how did this come out so late? How did this come out when you were 16 to 20? Didn't, you know, why wouldn't have this come out earlier? It's very common that people could know something about themselves, but not necessarily be ready to share it until they're older. The affirmative approach is an idea that rather than focusing on the child who is different and trying to give them therapy, you're giving tools to the family to help support the child, and just focusing on acceptance and unconditional love. To say, you know, whatever this journey is, wherever this journey takes you, you're just going to help your child. The child will end up wherever they end up, and that's fine, but you're going to help your child and protect them. So this therapist more focus on trainings in school to prevent bullying and helping to protect the child from sort of relatives who might be negative or be hurting the child, as opposed to, you know, trying to change the child in some way. They really find that family acceptance is so crucial for health of the LGBTQ children, that family acceptance is life-saving. It is so important, and it's protective against negative outcomes, and it's present for positive outcomes. Families are going through a lot. There can be, when a child is different, when a child is showing gender variance, families sometimes are surprised, or they don't know how to handle it. Sometimes they can be very proud of the uniqueness, but so worried for their child, how their child might be accepted or rejected or teased, or what the child might be facing in the future. Sometimes also parents think people might blame them or say, you know, you raised your child this way and this happened because of what you did. And sometimes uninformed professionals would say that kind of thing. That used to be sort of the psychological explanation for what was going on. And so families can be under a lot of stress and pressure as well. The American Academy of Pediatrics has a statement. It has resources. It has the support of the affirmative approach in helping children through a healthy transition. They have recommendations for medical resources. They have an office-based care for LGBTQ youth, again, about having the office, what to do in well child visits, et cetera, and it's a good policy. Again, this is just showing, again, the power of family acceptance for trans youth who have supportive parents. Life satisfaction, mental health is so much better, depression is so much lower. substance abuse issues, self-esteem is higher, they don't have housing issues, they can live at home, and suicide rates are so much lower. For people who have unsupportive parents, the risk of suicide is so much higher, homelessness, just the problems are much more serious. So again, when we're talking about, what are the sort of the things that we're doing, for prepubertal children, social transition is the main thing. And that's a decision about whether to change name, hairstyle, clothing. There's nothing really medical done, but there can be a lot of counseling because it is a big change to be known as a different gender. And so a therapist can often help, and support groups can also help if people do decide to go through with the social transition. There is a study that looked at the mental health of children who did socially transition early and their parents were supporting them. And they found that basically they had slightly higher rates of anxiety, but otherwise mental health was pretty much the same. And since there's so many studies showing that mental health rates are so much worse in transgender people in general, this article I thought was pretty remarkable, showing, if kids are supported and helped along, then they're just pretty much regular little kids. This is an article talking about chosen name, people who are, called by their name in different environments, at work, at school, at home, and with their friends. And they baseline characteristics were similar, but people who did have their name used in more locations found less depression, less suicidal ideation, and less suicidal behavior. So just being addressed how you want to be addressed can be life-saving. This it comes up a lot, that people just are very much doubted in their sort of ability to know themselves. And if somebody transitions at age 6, people will often, how can a 6-year-old know? How can a 6-year-old really know this? But if a 6-year-old is cisgender, if someone is assigned female at birth and says, I'm a girl, when they're 6 years old, nobody says, you're too young to know that. You couldn't possibly know that. Everyone says, okay, you're a girl. Everyone, okay, that's fine. So if somebody is acting outside of the gender norms, then they're doubted and they have to prove it, and they have to go through a lot. When we go through a diagnosis, a medical approach, the DSM V has a diagnosis for gender dysphoria. It's different in children and adults, but it's an incongruence between someone's expressed and experienced versus their assigned gender, at least 6 months, and it has several categories. And it's one of the big parts is, again, somebody really believing they are that gender, that's who they are. In children, it has more to do with behavior, with some of the categories that people might, how they want to dress and how they want to look and wear their hair and how they play, and the roles they play, but also dislike of anatomy and how they anticipate growing up, saying, I never want a beard like daddy, I want to look like mommy, I want to have a baby, for instance. In adults, it's a little bit more of how people might express themselves verbally. Someone who, for instance, might say, I'm a woman and I'm going to be a woman when I grow up, might verbalize it in that way, for instance. When we start to talk about physical interventions, there are 3 categories. Just talk about things that are fully reversible, things that are partially reversible, and things that are irreversible. These are looking at the pubertal development for people assigned female at birth. Tanner stage 1 is no puberty, Tanner stage 2 is breast budding, Tanner stage 3 is breast mounds, Tanner stage 4 when you have a secondary mound, and usually menstruation starts around there, and 5 is adult. And in terms of pubertal development for people assigned male at birth, 1 again is child, and when testicular size is 3 mLs or less. 4 is when you get to testicular size of 4 mLs. 3 is in the middle, around 10 mLs. 4 is about 15 mLs, and usually a lot of visual changes are happening at this point: deeper voice, facial hair, growth spurt, and 5 is basically adult. So GnRH agonists can be used, the same medications that are used for central precocious puberty to just pause puberty, can be used also for transgender adolescents and transgender children who have reached a pubertal stage of Tanner 2 to just put things on pause. This is a picture looking at Nicole Maines and her twin brother, and she was able to pause puberty, so she did not have to go through a male puberty. It really just stops estrogen and progesterone or testosterone production. It allows more time to explore gender. It can have some side effects, for instance, lower bone mineral density. People might have a slower growth in terms of linear growth because they're not having a growth spurt. And if you use it very early, you may have lack of fertility development. Other potential reversible options are birth control pills, that someone can use continuous birth control pills, or progesterone, or androgen blockers like spironolactone, finasteride, or bicalutamide. And those might be appropriate for someone who's a little bit further in puberty and already making hormones, but then we want to stop them or keep them continuous to stop periods, for instance. Gender-affirming hormone therapy can be used for older adolescents, although there's questions about what age to start, which really depends on the person. And there's sort of an idea of pure concordance that other adolescents who are cisgender are going through puberty at all kinds of ages, 10, 11, 12, 13, 14, 15. And so that transgender adolescents might also go through puberty at, 13, 14, and 15, for instance. In terms of feminizing hormone therapy, risks and effects should be on the other side. The effects are breast size increase, usually over 2 to 3 years, body shape changes, fat distribution, goes to a more curvy figure. If somebody's already been through puberty, then they would start to lose muscle mass. Facial hair and body hair would stop. Skin becomes softer, and usually sexual function decreases, testicular size gets smaller, libido goes down, sperm development stops. When we talk about the risks, blood clot risks are probably the biggest and scariest, and that's kind of true for anybody who has more estrogen. The more estrogen you have, the higher the risk of blood clot. Transdermal estrogen is probably the least risky of all the different types you can treat with. Prolactin levels could increase. Bone density will be lower than it would be if you had testosterone. Breast cancer risks could increase, but usually it's not as high as it would be for cisgender women. Spironolactone can cause dehydration or kidney electrolyte imbalance, so we check that and follow that. People do have emotional changes, and that's something that we talk about, but it's puberty, so people have emotional changes. When they found a morbidity and mortality in general from transgender women, it's not usually related, other than blood clots, not related to hormone therapy. It's been related to HIV, suicide, and drug abuse. When we look at masculinizing hormone therapy, the effects, people get increased body hair, increased facial hair, deeper voice, stronger, more muscular, acne and hair loss can happen. Periods should stop just from the testosterone when the level gets high enough, and usually people get clitoral growth and also some vaginal dryness. Risks in general, higher risk of heart disease, cholesterol patterns get worse. Similar to other men in the family, patterns would be like a cisgender man. The risk would be similar to, for instance, a cisgender brother. Polycythemia, so too many red blood cells. If you're using kind of typical levels of testosterone, it doesn't usually happen, but it could. Some people get really bad acne, but again, it's just similar to puberty. Sometimes insulin resistance can occur, so higher blood sugar can happen. Again, emotional changes. Some people get more irritable or short-tempered, especially when they start testosterone. And there can still be cancer risk. It doesn't increase cancer risk, but PAP testing, for instance, is still needed starting at age 21. So this is an article just looking at hormone therapy and then metabolic parameters over time in adolescents, and looking at a few different sites, looking at some trans men and trans boys and trans girls. We looked at baseline and then repeated over time. And basically, for testosterone, we found H&H went up, but then plateaued, and HDL went down. And that's basically expected from testosterone. ALT, AST, really nothing else actually changed. For the trans girls, prolactin went up also, which would be expected. Testosterone went down, but nothing else had actually changed. Everything else was about the same. It is important to be concerned about non-prescribed medications and treatments. People will try to get anything on the internet, or people will get things from friends or off the street, and you don't really know what you're getting with that. It's hard to control, but people will sometimes buy things illegally. People will share needles. People will sometimes use estrogen, Premarin, or other kinds of estrogen that might have a higher blood clot risk. So, if possible, again, harm reduction, trying to get people to use the prescribed methods rather than non-prescribed methods. And silicone injections is something that people will do as well. If they feel like they're not getting results from hormones, they'll pump silicone into parts of the body to try to get the figure or shape that they want, but that can have many really serious complications. So there have been studies looking at psychological outcome after puberty suppression and gender reassignment. This was from the group in the Netherlands. They looked at them before blockers, before hormones, and then after surgery, and they just found kids got better and better. And they basically found that at the end of the study, this group was just the same as their peers in terms of mental health. And again, as I mentioned, there's a lot of studies showing really high rates of depression and suicide and anxiety and all kinds of psychological issues. So having a study saying, that they're basically just generally the same as everybody else was, again, pretty remarkable. And so after this, the clinical protocol in terms of puberty suppression and then starting hormone therapy in adolescents, surgery if desired later, started being adapted by other clinics around the world. When somebody's identifying as non-binary, there are other kinds of medical options. It really depends on what the person's goal is. And sometimes puberty blockers could be used, but people cannot have no hormones indefinitely. So there needs to be some type of hormone for bone health, for instance. Some people use low dose of testosterone or might use estrogen without using a blocker. Some people use an IUD or Nexplanon or something just to stop periods if that's what's bothering them. And some people might have surgery without hormones. For instance, somebody might get top surgery to have a flat chest, but be okay with everything else and not take any hormones. Or somebody might have breast augmentation without taking any kind of hormones. These are some resources. Sex is a funny word is a pretty good inclusive resource for puberty and reproduction. And same thing for the Everybody book. It's the LGBTQ plus inclusive guide for kids about sex, gender, bodies, and families, which is good because a lot of times kids can feel very left out when puberty and sex education is only focusing on one type of puberty and then opposite sex relationships. The other magazine article is talking about a couple where each person is transgender and they had children together. So they're talking about just another kind of family. We talk about fertility. When somebody has used blockers from a very early point, then sometimes that can cause fertility issues because sperm and eggs can't be collected if there's only very immature eggs and very immature sperm. So discussions around fertility need to happen from an early point on, and they need to be developmentally appropriate. If somebody's already been through fertility, if they come to you after menstruation or after spermarchy, they could do fertility preservation, and then those conversations also need to occur because some people might have that as a priority and some people might not. Not many people go through with fertility preservation. There was one study where 72 people, adolescents were counseled and only 2 people decided to go through with attempted fertility preservation. If somebody's pre-pubertal or in early adolescence, the question is, can you do any kind of fertility preservation? There are some experimental methods and some very early methods. For instance, taking an ovarian cortex, there have been births reported from this method. Again, it's very invasive, it's a surgery. They're trying that type of thing as well on testicular tissue, but there's not really been any actual results from these methods yet. The other thing to consider, though, is a lot of times we're focusing on people losing fertility. People might also still be fertile, especially if they've already been through a typical puberty and then they are on hormones, they might still retain that fertility. And so contraception is still very important. A lot of people think, oh, I'm not having a cycle anymore, therefore I couldn't possibly get pregnant, and then it's not actually true. When they had done one study in 2014, they looked at pregnancies in transgender men, and most of them are on testosterone, not everybody, but I think 85% were taking testosterone, and 1/3 of the pregnancies were unintentional. 2/3 were intentional, 1/3 were unintentional. So very important to use contraception if not planning for a pregnancy. Same thing for transgender women. They might think, I'm on estrogen, there's no sperm being made, but there could still be sperm that's being made. In one study from the Canadian Transgender Youth Survey, they found that 5% of sexually active trans youth had been involved in a pregnancy, and that was just the same as the average of cisgender youth. So pregnancy can still be an issue. This was an article where, also from the Netherlands, that they looked at sort of sexual experiences in trans youth, ages 11 to 17. And they found that they were less experienced than cisgender peers. And that's what they sort of had hypothesized. But then they were also kind of surprised that they did have experience. They really thought they wouldn't have much. They were more experienced than they expected. People were falling in love and they had romantic and sexual experience. The survey itself was somewhat limited because they only asked about penis and vagina sex. And so that was really limited for a group of LGBTQ youth. It was interesting because they asked about, and reasons you were not having sex, it was because you were uncomfortable and dissatisfied with your body. But they didn't ask that of cisgender youth. They only asked that of transgender youth. So I thought that was interesting too. And they also didn't delineate for people on puberty blockers. So that's kind of pre-pubertal people, even if their age was a little bit older. And so that also could definitely affect libido and sexual activity. But point is, in taking a good sexual history, it's important to ask people who they're attracted to and what they're doing, and if they're using protection, and it's not good to make assumptions or not to discount different types of activities. There's another article that looked at transgender adolescents and asked more open-ended questions. And they just asked people about their relationships, and they found different themes, romantic histories, what parents had rules about, what was the relationship like, was it harder than with other friends, was there transphobia in the community and the dating apps they were using, what was it like with disclosure, what was it like, were there abusive relationships, emotional abuse and sexual assault, and what did they think about hormone therapy? Did it help? Did it hurt? What was it like to be on hormone therapy? And they found that they thought hormone care helped with comfort and with confidence in their bodies. And then they felt that it helped them to pursue more romantic relationships. We talk about mental health in the LGBTQ community. There are much higher rates of depression, higher rates of suicidality, more than 4 times likely to attempt suicide. And issues, this is mentioning that issues like restroom access, and part of that has to do with just basically being respected or not respected, and how people are treated. And this was saying that people being sad or hopeless and kind of experiencing, anhedonia, not doing their activities. So it can be pretty significant. Again, depression, anxiety, there's high rates of self-harm, suicidality. There can also be violence, victimization, and bullying, such as in schools. And then body image issues can be pretty significant, and also high rates of eating disorders. This was an article that looked at mental health, drug and violence intervention for sexual and gender minorities. And then they looked at different articles to see what were the different types of interventions and what were they like and how did they work out. And so they found that there were some that were policy interventions, things that were aimed at state level policy. Some were therapists, family-based interventions, so like families would come in to kind of meet with a social worker, with therapists. Some were computer training, some were online interventions, and then some were basically like a gender program, gender affirmation, medical intervention. And they found that basically all of them actually helped improve things, that all of them helped with the targeted outcomes, to decrease depression, decrease bullying, reduce substance abuse. So, the design, I think, wasn't as important, just kind of stepping in and doing something and helping with the population, help to improve things. This is, again, Nicole Maines, who I mentioned before. She had transitioned when she was very young, and now she's an actress, and she was on, I guess, Supergirl. And she said she felt very blessed and lucky to grow up in the environment she did, and her parents really stood up for her. They had, I think, sued the school district when they didn't let her use the girls' bathroom. And she's, I think, a successful actress. And I think that's, there were so many things when we read all these statistics and everything else, that this many kids have this terrible thing and this many kids have this terrible thing. But I think it's also very true. I see so many kids, I have so many patients who do these really wonderful things. They go to great colleges, they get great jobs, they have good relationships. There are a lot of kids struggling, but there are also a lot of kids who, really are succeeding and really doing well. And I think that's important to remember too. So these are the local referral resources. There are some really great places in Baltimore and surrounding areas. Some of these are medical resources and programs like Star Trek and Chase Brexton Healthcare, healthcare for the homeless. Those are places people can go and get medical care. Youth Empowerment Society Drop-in Center in Baltimore Safe Haven are places that youth can go for help with food, clothing, resources, who are experiencing homelessness. And these are some of the national resources. Some of these are places, again, that have different trainings. Things like the Trevor Project and Trans Lifelines are places people can call if they need, for instance, someone's having a crisis, they can call, or if kids need someone to talk to. This is just some additional resources. The Trans Line is an online medical consultation service. So for instance, somebody had a medical question, how do I dose testosterone for this or something like that, they can send a message to that group. It's a group of physicians who answer those questions. And I manage a group on a Google group with some other physicians, and it's called PATH, or Pediatric and Adolescent Transgender Health Interest Group. And it's for professionals, and people can, again, post a question, case or a question or resource to ask about something, because in this field, there are many more people doing it now than 10 years ago, but still sometimes it's very hard to find somebody to just ask a question. It's not like you're asking a question about diabetes and everybody is doing it. So it's really nice to be able to find that and to be able to kind of get information from colleagues around the country. All right. Thank you, and I'm happy to answer questions.
Thank you so much, Dr. Pine. That was a lot of information that you fit in that amount of time, and we really appreciate it. And I did want to say for our audience, thank you again, Dr. Pine, for compiling all of those local resources and national resources. We do have a document that will be posted on our website along with the full recording of this session and your slides. That'll be posted on our website. And then when you get your CME or CE certificate in a few days, you'll get a link to that as well. So we'll have those out to you in the next few days. We are to our question portion, so please go ahead and put your questions either in the chat or the Q&A, whichever is easier for you to use. We do have one question that we'll go ahead and start off with. How long can someone be on hormone blockers?
So that's a good question. I get that from a lot of parents. What I would say is it's not necessarily an amount of time per se, as much as how long can a person not be in puberty for. And the reason I say that is, initially it's used for people in central precocious puberty. I had a patient who's 15 months old in central precocious puberty. It's perfectly safe to use puberty blockers for a 1-year-old until they're 10. So 9 years is not a problem. You can use it for 9 years. It's perfectly safe, because you're not supposed to have hormones when you're 2, 3, 4, 5, 6, 7, 8, 9 years of age. Does that make sense? So, you're not supposed to have estrogen or testosterone in your body from ages 1 to 10. So for that kind of child with central precocious puberty, we would use it from age 1 to 10, 9, 8, 9, 10, whatever, and stop it around then. And that child would then go into puberty and have a normal amount of hormone exposure from ages 10 to adulthood. Now, if a child comes to me at age 8 or 9 or 10, and they're starting puberty, we could use it for a few years. But if we used it for 10 years for that child, they would have no hormone exposure from age 8 to 18, and that's really dangerous. That makes no sense. I don't want to say it makes no sense. It wouldn't be safe. It wouldn't be safe. So that is a different story, because you're supposed to have hormones sometime. Puberty starts between 8 and 13 or 9 and 14. But there's some kids who are 8 or 13 or 14 and have no hormones. We're not because of blockers. They're just naturally late bloomers. They have no hormones. We don't run around putting them on hormones and grabbing them and putting them in DEXA scans because their bones are so weak. They're just normal. That's just the late part of normal. So if you have a kid who's, 13 and is going to be on blockers for a year or two, is that so very different from another kid who's a late bloomer and is going to be on hormones for a year, on blockers for a year? Or if you have a kid, for instance, I get kids who started puberty at 8, they went through 5 years of puberty, and now they're coming out as transgender at 13. they already had 5 years of estrogen exposure. And now they're suffering from very bad mental health issues. They're suicidal and having, menstruation issues or whatever. Putting them on blockers for 3 years may not be such a bad thing. They already had 5 years of estrogen exposure. Taking away estrogen for 3 years, how is that different than a kid not having, estrogen from 8 to 11? It's sort of the total number of years of hormones that you get, because you build up your bone density from puberty to 25 to 30, and then it goes downhill. So you get your total number of years to build up as much bone density as you can. And so the less hormone exposure you have during that time, the more dangerous it is for your bones. So if, for instance, you use puberty blockers for someone who's never been on puberty and never had any kind of puberty, use it from age 8, and you're still 16 and you haven't been on any hormones yet, that's kind of dangerous. But if you have a kid who already had puberty, full puberty, menstruating, everything, 14, and they use it for 2 years till 16, I'm not quite as concerned. So it's not, I wouldn't say it's a number of years. I would say it's how many years of no hormone exposure. How long have you been without any hormone exposure versus how much hormone exposure have you had? And that's what you're balancing out.
Great. Thank you for addressing that. Makes a lot of sense, a lot to balance there. So we have another question. How do you recommend handling when adolescents decide to start hormone therapy and then perhaps have doubts about whether to continue it or are inconsistent in their adherence to the therapy?
I'm sorry, can you repeat that?
Sure. So how do you recommend handling when adolescents start hormone therapy and then maybe they're having doubts about it or they're not great at their adherence to the therapy?
I mean, I think I would try to find out if the adherence issue has some kind of barrier. If, for instance, somebody is not great at taking shots, but it's because they have needle phobia and so they don't want the shots, but they really want the hormones, then is it just the method of what they're doing? But most of the time with most of the things, you can always do it later. So if somebody is having doubts, they can stop and they can always try it later. Like for instance, with testosterone, the deep voice, you could get a deep voice later. If you take testosterone at 18, it will do the same things as if you take testosterone at 25. So if somebody is saying, I'm not sure if this is the right pathway for me right now, they can stop hormones. They can do some of the reversible things. If they are assigned male at birth, they could take spironolactone to try to just lessen the effects of testosterone. Or, if they're assigned female at birth, they could, for instance, take birth control or progesterone or something to stop periods if that's what's bothering them. They don't have to take testosterone during that time. There's many more things that are involved with gender other than hormones, and you can be a man without testosterone. You can be a woman without estrogen. You don't have to go through with a medical transition if it's not the right thing. And if it's the right thing later, it'll be the right thing later. If it's the right thing later, you don't have to do it kind of right now. So especially if someone's not sure, they can hold off on it and they can always go back to it later.
Great. So there's definitely some flexibility there. That's good to hear. We have another question. Do you feel that agonists or hormones should be prescribed or started in a primary care setting or should always be referred to an endocrinologist or transgender specialist?
So I think that it could be prescribed in a primary care setting if the person has training and experience in using it. And I think that and I know right away when you start, you don't have training and experience, but you have training and then getting experience because everyone starts somewhere. So I don't think it has, I think GnRH agonists might be a little bit harder. Just sometimes insurance companies, for instance, require a specialist to provide them. But I feel like with hormone therapy, if you go and do some of the trainings, I think it can be done in the primary care setting. I think it's important to be trained and very well familiar with everything because it's important to know how to do, how to discuss fertility, how to discuss mood changes, and the physical changes, kind of all of it.
Wonderful. So we have a few times heard on the BHIPP line that some families are not so accepting and how to navigate this. So I was wondering, I know you discussed the affirmative interventions for families, but how do you navigate when a family is really just not accepting of a gender identity or sexual orientation for their child?
It can be very hard, and it kind of depends on how willing the family is to listen. Try to start from the same place of understanding we both care about your child. We both, you know, want to do what's right, and kind of understanding they want to do what's right also. Just what they think is right might be different than what you think is right. And so just trying to come to a place where you can help them and just even if, for instance, they're not ready to kind of do anything medical, just trying to get to say, calling the name, using the name might be, or using something neutral if they can't use the name, or using no pronoun, or using a name versus using the pronoun that's hurtful, and just kind of like getting to that place, and also kind of, just to say, and I would say in a positive way, that you're here in this visit talking with your kid, that you love your child so much. I can see how much you love your child so much, that you're here and trying to help them. And and what they need right now is your support, and you don't have to do this and this, but just supporting them and showing you love them. And what about using this name? Doesn't do anything, it doesn't change the body, it doesn't hurt, just kind of, and getting them hopefully to a place that is less distress, and getting the kid to a place kind of, again, of less distress and more acceptance. So just kind of in those steps of eventual, and they may not accept their child, but hopefully in that place. I also try to find out sometimes what exactly it is that's causing, what are they concerned about? Is it a religious objection? Is it a scientific objection? Is it a cultural objection? What kind of is the thing? Because there are a lot of religious resources, and sometimes connecting in that way can help. I find that PFLAG is really helpful. Also, again, some families might not really be ready to go if they're very rejecting, if they're just, this is all craziness, I'm not going to go. But there are also families in PFLAG that sometimes will kind of just one-on-one reach out and meet with other families that, I was where you are. This is how it went for my family. This is how I felt, and this is how I'm feeling now. And kind of making those very, small steps to, again, just try to move the needle to just a less distressed place, because it's sometimes kind of like a crisis in that, very rejecting space.
Yeah, definitely. So it sounds like you're kind of emphasizing, in line with that, harm reduction, trying to find some compromise between the family of using a different name or things like that. And it's great to know there are resources specific to those concerns of religious communities and things like that.
Right. And I think, and eventually sometimes parents do get to, well, that's where I was, and now after a year or after 2 years, now I do see my child really does need this hormone, and they'll eventually consent to it. Like, I've seen some big changes over time, but that doesn't happen instantly. And if you can't just kind of say, yeah, you must do this, that's not gonna.
Yeah, they need more support and more education about this.
Yeah.
Doesn't come with a manual. So,
No.
right. So we have another question here. Where would you recommend a practice start in trying to shift their practice climate and workflows to be more gender affirming?
I would say that it would help to do probably if you have times that you do practice trainings, that there are trainings that are interactive and I think helpful, because those are, I think people learn more when they're doing a more interactive kind of thing. And if you could do it with the whole practice, even, and just some things, for instance, if you're trying to make it more inclusive or something, using pronoun pins or something like that. And if like the whole staff is going to use them, then you introduce it to the whole staff and kind of do a training on sort of like, why is this helpful? Why is this, why would it be hurtful if somebody is getting the wrong pronoun used? Because I think otherwise people wouldn't know and they wouldn't understand. And I think once people understand, nobody wants to hurt someone's feelings. Nobody wants to, hurt the patient who's coming in. So if someone I think without explaining why you're doing it, people might be like, what is this? But doing it kind of together with the training, people might say, okay, I understand why we're doing this, and I understand that it will make people feel more comfortable.
Yeah, great. That's a great action step for our practices and some reasonable changes that are quick to make. So we probably have time for just a few more questions if there are any. And for our audience, as I said, the slides and recording will be available, and the CMEs and CEs will be sent in 3 business days. And just a reminder, as you leave, when you close this window, a survey will pop up. If you could please complete that, that would be wonderful. So it looks like we have another one here. Could you speak to how your practice has handled addressing mental health issues within the practice?
I'm very fortunate that I work in a multidisciplinary environment. It's different than where I'd worked in the past. So we have behavioral health that's separate. We have behavioral health that they have their own appointments and everything, but we also have behavioral BMed, which is the behavioral medicine, someone who's available sort of for like crisis intervention. And so, for instance, if I'm with somebody and the person tells me they're suicidal and they have no hope for tomorrow and they've been thinking about a plan, then I can call that person to come down and sort of meet with that person one-on-one to help determine, do we need to do an emergency petition, or can they help develop a crisis intervention plan, or kind of what do we need to do. So that's kind of how we can help with sort of an acute mental crisis. We do have, again, kind of ongoing therapy. We have a few support groups that are going on. So if somebody, for instance, is not needing kind of a crisis, but we have one that's called Life Skills for Transgender Teens, and it's like a 12-week support group with a theme for the week, and they kind of go through other things, and that's really, I think, helpful. You can meet other people and kind of go through different topics and process things. But people often have their own therapists. People don't have to get therapy through Chase Brexton. And we also use an informed consent model. So we also do not require that people have a therapist. So a patient could come in and get medical care without necessarily having a mental health provider. However, if somebody comes in and they have significant mental health issues, then they may need to see somebody for mental health before they can get medical care. If, for instance, they have high rates of, high level of depression or eating disorder or something else going on.
Great. So it sounds like very integrated model there for those that need it. That's wonderful. Probably this is our last question. What does the research say for youth detransitioning, and what are the reasons?
That's a good question. There was a new article that just came out. I think Jack Turbin wrote it. So there are people, I think this makes it, the more people that transition, the more people are going to detransition. So there's going to be detransitioning, especially since more people are transitioning. They did an article and they kind of looked at all the people who detransitioned, and the majority detransitioned for external factors as opposed to internal factors. And what I mean by that is most people were detransitioning, I lost my job, I lost my family, I lost a relationship. So sort of not because I don't actually think this is who I am, but more my church kicked me out or something like that. So sort of along the pressure of another person. But there were internal reasons as well. And for instance, people often felt this isn't the right decision for me anymore. This is how I felt, but I don't feel that way anymore. Or I don't feel my gender identity is this anymore. And I would say that, but they also, in that, not everyone who detransitions has regret either, because detransition and regret are actually two different things. And I would say that that's been my experience, is that I've had people, I don't even know if detransition is right, but I've had some people detransition. I've had very few people who actually go back to their cisgender original identity, if that makes sense. I've had very few people kind of end up where they started. So if somebody kind of started assigned female at birth, transition to living as transgender male, and often end up something more like non-binary. They might stop testosterone and they're like, I no longer feel male, but many people do not necessarily feel female any either. They, for instance, I've had two different patients go back to using she, her pronouns, but a different name, and love having facial hair and a deep voice. So not exactly kind of, oh, I'm sad I did this and I'm a woman and that was not the right choice, but also not wanting to be on testosterone anymore. So I'm not saying I'm a man, which is what each had originally said. So I think there's definitely, just as in any other sexual identity, gender identity, there's fluidity. Some people have a very different journey over time. And there can be some people who, for instance, might just say, that was not the right decision for me. It was trauma. It wasn't actually, a gender identity issue. That's not what it is. And I'm going to live back to how I was. I have not seen many people like that, but I'm sure there are people like that. But I have seen more people say, I'm going to stop hormones because I actually feel I was here and now I'm here and I'm actually now here somewhere else. And people kind of end up even on a different path. And I've seen that a few times.
Okay, and it looks like we do actually have a few more questions trickling in if you have the time. We have one here. I have a patient that is 18-year-old female that is seeking birth control. She reports to me that she is thinking she is transgender. What recommendations do you have for this situation?
Well, I mean, I think that birth control can be used for contraception or for menstrual manipulation, pretty safely anyway, if that would be helpful for the patient. I think in terms of gender identity, it might be helpful if that's something that the patient is kind of exploring, then either seeing a therapist or going to some of the support groups might be helpful in terms of trying to talk out and figure out, is that the gender identity, and if so, is there something that she wants to do about it, or how is that kind of, what is that meaning for her? Is that something that, as she's kind of figuring out what's going on, it might be helpful to talk that through.
Okay, great. And then our last kind of clarification question, is it okay for patients to stop and start hormone blockers?
Yeah, I mean, so what I would say is, some people start hormone blockers very early, like right at the very beginning of puberty. And if they did that and then they stopped, they would just go through puberty. So it's, they're reversible. It's one of the great things about them. And so I've had a few people who started and said, you know what, that's not the right path for me. And they stopped and then they just went through puberty. If they started and stopped, they would keep going through puberty. If that was a problem for them, like if they were really anxious, if it was someone who, for instance, was a trans boy and he was very, very anxious about breast development and periods, and he kept starting and stopping, he would develop breasts and periods. So that would be a problem for him in that aspect. Same kind of thing if it was a trans girl who had started very early and then stopped and started, that could cause, voice change. The more testosterone exposure, the more voice changes and other things like that. If it's someone who's already been through puberty completely and then you're using it to just stop it temporarily, again, you could start and stop. It would just be, a period of time with no hormones and then a period of time with hormones. People use Lupron for things like endometriosis and IVF. So people are used to getting intermittent blockages of their hormones. It's possible to do. I would say the only kind of question is sort of, what would be the purpose of using it or not using it. But health-wise, it could be done, again, sort of if someone, you know, was on it and then they said, no, I don't want to be on it anymore. And then they said, no, I really need it again. You know, we could use it again for a period of time.
All right, wonderful. Well, thank you so much for addressing all of these questions and for this presentation. It's a really needed presentation for our audience, and we appreciate your time today. And thank you as well to all of our attendees.
Thank you.